Hello again. This time, in the fourth lecture of gastrointestinal diseases, we are going to discuss a very important issue again. This is the dysfunction of the oropharyngeal sphincter and cardioesophageal sphincter. Oropharyngeal sphincter is in the most proximal part of esophagus, and cardioesophageal sphincter is the most distal part of esophagus. And these sphincters are regulating the transmission of food from oropharynx to stomach. First, we start with oropharyngeal sphincter. This is an part of macellaris propria of esophagus. In oropharyngeal area, there is a thickening of this muscle, which forms a sphincter that when there is no food in stomach, it is constricted. So it does not give way on the other side, I mean, from esophagus to oropharynx. But when we eat or drink something, this sphincter will be relaxed and the food bolus will find its way into esophagus. Then, with the relaxation of the cardioesophageal sphincter, the distal part of esophagus, it will be transmitted into stomach. And when the stomach is full, the digestion starts with the secretion of gastrin and hydrochloric acid. And in this case, the cardioesophageal sphincter is constricted. So in physiological conditions, there is no reflux from stomach to esophagus. However, the dysfunction of these two sphincters are very common, and today we are going to discuss this issue. We first start with dysphagia. In definition, dysphagia means difficulty in swallowing. In physiological state, we are not aware of the swallowing process because it is happening automatically. But in patients with dysfunction of either of the sphincter or both, there is a difficulty to swallow liquids and also solid foods. Odynophagia means painful swallowing. It is somehow different from dysphagia. In dysphagia, there is a difficulty, but in odynophagia, there is a pain in swallowing. It generally happens in the conditions which are characterized by the destruction to the esophageal wall. For example, some ulcers due to some pills, because some drugs, when they are not taken with a large amount of fluid, may cause some ulcerations in esophagus. That is, for example, very common with tetracycline type of drugs. Regurgitation means reflux of the swallowed food from esophagus to mouth. And rumination means swallowed food is refluxing from stomach to mouth and swallowed again after chewing. Rumination is a natural process in some animals like cows, but in humans it is a disease which usually happens in either elderly population or in some patients with psychological disturbances. Oropharyngeal dysphagia, this is a different type of dysphagia, means difficulty in passing the food from mouth to esophagus. In a classical dysphagia, the food bolus is impacted or in difficulty to go from esophagus to stomach. But in oropharyngeal dysphagia, actually the affected subject is not able to propel the food from oropharynx into the esophagus, and it is common in elderly population. And when we look at the scope of the problem, the overall prevalence of dysphagia in individuals over 50, it is from 16 to 22%. So you see it is very common, 1 in 5. Prevalence in healthcare institutions, it is 22%. And in nursing home residents, so these are the people, mostly elderly population, it may be up to 60%. What are the complications of oropharyngeal dysphagia? Oropharyngeal dysphagia is highly frequent in nursing homes and in elderly population in anywhere. Because of difficulty in swallowing food and liquids, in such subjects, there may be severe dehydration, malnutrition, aspiration, choking, pneumonia, aspiration pneumonia, and even death. You should take into account that in nursing home residents, one of the most frequent cause for death is oropharyngeal dysphagia. It may have, in general, dysphagia may have mechanical causes or neuromuscular causes. We start with mechanical causes. And the first, we start from proximal to distal. In the most proximal part of esophagus, some web-like structures may be present. And this is happening mostly in subjects with iron deficiency anemia, and it is much more common in females. So in a female patient with iron deficiency anemia, if there is difficulty in swallowing liquids and solid food, first of all, we should suspect Plummer-Vinson syndrome. The Plummer-Vinson syndrome is also called as Patterson-Kelly syndrome. Peptic strictures are quite common in Western societies because of the high consumption of high amount of alcoholic beverages. But in our country, it is not so common, but it still happens. Schatzky ring is a type of peptic stricture which happens in the patients with hiatus hernia. Corrosive injury is due to the accidental intake of some corrosive agents, or for some instances, these may be taken as a suicidal agent. And it causes severe injury in esophagus, stomach, and even intestine. Goiter, the enlargement of thyroid, is another cause for mechanical obstruction of esophagus. It is not quite common nowadays because until thyroid enlargement is reaching this very advanced level, it is generally treated. Eosinophilic esophagitis is also common in Western population. Its cause is unknown, but there is an increased eosinophils in esophagus, and it causes strictures. In our country, eosinophilic esophagitis is not quite common, and in children, it is more common than adults. Zenker diverticulum is an sac of proximal esophagus, and in this sac, the swallowed food will accumulate, and it causes difficulty in swallowing. It may also cause regurgitation and aspiration pneumonia. Retropharyngeal abscess is another cause. Lymph nodes and some cardiac and lung-related conditions may also cause external compression of esophagus. Malignant tumors, squamous cell carcinoma and adenocarcinoma, are also common causes for esophageal obstruction. Subepithelial tumors are a type of tumors that their surface is covered with healthy esophageal mucosa. In squamous cell carcinoma and adenocarcinoma, there is involvement of mucosa, but in subepithelial tumors, mucosa is patent. it is normal, and the pathology is in the wall. In leiomyoma, that is an tumor of muscularis propria, there is obstruction due to the enlargement of muscularis propria. Leiomyoma is mostly happening in esophagus, rarely in stomach or other organs. It is completely benign condition. And if it does not cause dysphagia, we do not treat it. But if it causes disruption of swallowing process, so it causes dysphagia, then it should be treated either by endoscopic or surgical means. On the other side of the coin, there are some diseases which are characterized by motor function disorders. Motor function disorders means that there is no mechanical obstruction, but the swallowing process requires an harmonic function of a nervous system of GI tracts. If it is local and is sometimes systemic, neurological function is disrupted, swallowing is affected. And on top of the list, there is a disease which is very well known, achalasia. Achalasia, we are going to talk about. This is the most common motor function disorder causing difficulty in swallowing, dysphagia. Other types of motor function disorders are nutcracker esophagus, jackhammer esophagus, diffuse esophageal spasm, scleroderma. This is an systemic disease, that's also called as progressive systemic sclerosis. And some parasitic diseases like Chagas disease may also cause motor function disruption of esophagus. Chagas disease is not common in our country. It is mostly common in South America. We discussed the issue of oropharyngeal dysphagia, and I told you that this is more common in elderly population. And the causes are cerebrovascular accident, Parkinson's disease, amyotrophic lateral sclerosis, multiple sclerosis, brainstem tumors, and peripheral neuropathies. These are all characterized by dysphagia in the oropharynx area. There are some myogenic motility disorders causing oropharyngeal dysphagia as well. For example, myasthenia gravis, polymyositis, myogenic dystrophy, and oculopharyngeal dystrophy. These are rare conditions, but the result is a very severe disturbance because the patient is unable to swallow food. And as we discussed previously, it may result with dehydration, malnutrition, and eventually death. In addition to this, there are miscellaneous causes for dysphagia, and saliva secretion is very important in swallowing, because if there is not enough saliva, then swallowing process will be negatively affected. And decreased saliva secretion is present in a Sjögren syndrome. You are going to learn about this disease in the forthcoming grades, but you would remember it as a name. Radiotherapy also causes decreased saliva secretion, and some medications with anticholinergic side effects will also decrease saliva secretion. And in these conditions, there may be difficulty in swallowing, dysphagia. Achalasia, the most common cause for dysphagia in reference to neuromuscular causes is happening in 1 in 100,000 person per year. So it is quite uncommon disease. prevalence is 1 in 10,000. There is no sex difference. And the pathology is in the ganglionic cells of mesenteric plexus. There are two types of neurological end plates in esophageal muscular wall, Meissner and Auerbach plexus. In Auerbach plexus, there is a loss of ganglions in this disease. It is probably immune mediated, so there are some antibodies against this mesenteric plexus, but we do not know the exact cause. But the result is destruction of this neuromuscular structures, and the result is that when the food reaches the distal part of esophagus, because of the destruction of this plexus, relaxation does not happen. So if relaxation does not happen, the food will accumulate in esophagus, and it cannot go from esophagus to stomach easily, only in small amounts. So the patient is suffering from dysphagia. There is loss of peristalsis in esophagus, in addition to absence of relaxation in lower esophageal sphincter. In contradistinction to mechanical causes, in achalasia, swallowing liquids is more difficult than solids. In mechanical causes, liquids can be swallowed to some degree, but solids are the most difficult. But the vice versa is true in achalasia. This is a patient diagram depicting the situation in a patient with achalasia. Sphincter is not working properly. There is a spasm. The food and liquids are accumulated in esophagus and dilation. This is esophagogram. You see, this is like a bird, and the beak of the bird, and esophagus is dilated, and some levels due to the accumulation of fluid. An endoscopic picture, the sphincter is constricted, no relaxation, and huge dilation of esophagus. The best diagnostic modality for achalasia is manometry, and we are also going to learn about this in the fourth class. Now we are switching much more common disease than achalasia. This is reflux disease. Reflux disease is very common in the society, and I am going to say that every people in this or that time would feel some reflux. But in most of the people, it is transitory. But in some people, it would be persistent. And in this case, we call it as reflux disease. Reflux disease is considered in three titles. The first is gastroesophageal reflux disease. In gastroesophageal reflux disease, there are some mucosal changes in the distal part of the esophagus because of the reflux acid effect on the mucosa. Esophageal mucosa does not have a mucus layer enough thick against the harmful effect of hydrochloric acid. Because of this, once this hydrochloric acid is refluxed into esophagus, it will damage the esophageal wall. It usually happens in persistent exposure. In some patients, there is reflux symptoms, but no erosion, no change in mucosa. This is called as non-erosive reflux disease. And in some patients, the disease is present in oropharyngeal sphincter. So oropharyngeal sphincter is not constricted properly. So in opposite to dysphagia, and the esophageal content would reflux into the pharynx area. The cardinal symptom of reflux disease is heartburn. Heartburn means that there is a burning sensation in chest. In some patients, when it happens, the patient will be alarmed that this is a condition related to heart and would go to casualty departments with the suspicion that he or she is having a heart attack. But finally, the diagnosis of reflux disease is made. In addition to heartburn, in some patients, there are symptoms of chronic sore throat. So it may be confused with chronic pharyngitis. But nowadays, ear, nose, throat specialists are very well educated about this. So once they examine a patient with the symptoms like chronic sore throat, they immediately think about reflux disease and they refer this patient to gastroenterologists. In patients with reflux disease, nighttime symptoms are very common because when the patient is in recumbent position, the reflux will increase. And this patient would be awakened at night with cough and rarely with some asthmatic attacks. So this condition may also be confused with some lung diseases. In some patients with reflux disease, there may be dysphagia as well. And I am going to say, in the general population, the most common etiology for dysphagia are not the disorders we previously talked over, but reflux disease. Because in reflux disease, there is an irritation of the distal part of esophagus, and the patient may feel some dysphagia. You see the mechanism of reflux disease. So the stomach is filled with hydrochloric acid and food. So in healthy state, this sphincter should be constricted, but now it is relaxed and the content is refluxing into the esophagus. Some toxic agents also promote these reflux symptoms. For example, cigarette smoking. Cigarette smoking is an important cause for reflux disease. In addition to cigarette smoking, obesity is also an important factor. Reflux disease is much more common in patients with obesity. The endoscopic picture of gastroesophageal reflux disease. You see, due to the chronic exposure of the lower part of esophagus, there are some erosions here. So this is classical reflux disease. In addition to this, you see there are gallbladder stones, which are common in patients with obesity as well, and liver steatosis. We generally find these diseases together because all of these conditions are related to obesity. So reflux disease in esophagus, stones in gallbladder, and increased fat in liver. So I am going to say that why reflux disease is so common in the society. This is because poor eating habits. This is hiatus hernia. In hiatus hernia, a part of stomach is in the chest. You see, this is cardioesophageal line. This is esophageal mucosa. This is stomach mucosa, columnar epithelium, and squamous epithelium. This line should be here, but now it is there because some part of stomach is in chest. These are stomach pili. In reflux disease, in endoscopy, we find an non-constricted and relaxed esophageal sphincter, and you see this is a mild reflux disease. This is moderate. This is relatively severe, but this is very, very severe. You see, you contrast this one to this one, and you are going to see that the esophageal, cardioesophageal sphincter is very, very large, relaxed, and these patients needs actually surgery to improve their condition and the ulcers here. Interestingly, the symptoms of the patient is not correlated with the severity of this physical state. So, for example, in this patient, there may be very severe symptoms, but in this patient, there may not be any symptom at all. It is very interesting, but it differs from patient to patient, and there is no correlation between the severity of the disease in morphological sense and the complaints. Eventually, in these patients, some mucosal transformation will happen. This is called as paretoesophagus. Paretoesophagus means that the distal esophageal part of the mucosa will transform from esophageal mucosa to stomach type of mucosa. This is not something good, because if some cells are present in their original location, this is okay. But if the cells are present outside of their physiological place, then this is a problem, because this may result with malignancy. This is classical Barrett's disease. Squamous epithelium of esophagus and columnar epithelium of stomach. And you see the stomach epithelium is penetrating into the squamous epithelium. In these patients, there is a 2 to 3 in 1,000 per year risk of esophageal carcinoma development. It is not quite common, you see, but still these patients need close surveillance. And if we find some dysplasia, actually we take biopsy from here. And if we find some dysplastic tissues here, we generally resect this tissue endoscopically. The treatment is outside of our scope, our coverage. But we recently developed an endoscopic system with some foreign colleagues to treat this condition without surgery, with endoscopic means. And you see after treatment, the relaxation improved, and the cardioesophageal sphincter is strengthened. This can also be done with surgery, but we currently do not use this device because it is very, very expensive, around 5,000 euro. Despite we developed this device, now we are not able to use it because of the economical concerns. Actually, the management, the treatment of the reflux disease is outside of our coverage today. But in the 4th grade, you are going to learn about this. So this is the end of our 4th lecture. In this lecture, we discussed the issue of dysphagia, and then we talked about reflux disease. The reflux disease, as I told you, is very common in society. Thank you very much.